Good morning, and welcome to a special talk on Indigenous health history by Dr. Samir Shaheen-Hussain, entitled Fighting for a Hand to Hold, Confronting Medical Colonialism Against Indigenous Children in Canada, named after his McGill University Press book. All proceeds from the book go to Indigenous-led charities. Bienvenue, Samir. I can see you on there. This lecture and the series as a whole was created for students in History 3590, Indigenous Health History, a course here at the University of Winnipeg. And it is made possible through the work of those at the 1L10 studio at the University of Winnipeg. This lecture is also open to the public on Zoom, and we welcome those who are joining us that way as well. The question and answer period at the end is reserved for the class only. And so after the lecture, we're going to ask everybody who's coming in on Zoom to sign off. Dr. Shaheen-Hussain is an assistant professor in the Faculty of Medicine at McGill University and a pediatric emergency physician in Montreal. He's active in social movements in solidarity with Indigenous people, including those addressing police brutality and documenting state violence in healthcare. So his book is a deep description of the non-accompaniment rule, which bars parents and others from accompanying Indigenous children during medical evacuations. So in the book, he puts this practice into the context of a long history of violence, discrimination, and structural indifference in provincial and national healthcare systems in Canada. So I appreciate you making the time to come and speak to us all this morning, and I'll turn it over to you now.
Thanks so much. So I'm going to share my screen. All right, hopefully everyone can see that okay. So thank you again, Mary Jane, for the kind invitation and the introduction. I'm not going to go over my introduction since you've already done it. I think it's important for me to acknowledge the land I'm on in my own position. And so I would like to begin by acknowledging and or recognizing that I am a racialized second-generation settler born to parents who immigrated here from South Asia, a region impacted by British colonialism. The place I call home is located on unceded Indigenous lands, and the Kanien'kehá:ka Nation are the custodians of the lands and waters where I live in Tio'tia, or Munyang, commonly known as Montreal. Canada exists because of land theft and genocide against Indigenous peoples, and settlers continue to benefit from these violent colonial injustices to this day. The diversity, resistance, and resurgence of Indigenous peoples and nations across Turtle Island are vibrant and ongoing. My responsibilities as a racialized settler include commitments to being in direct opposition to colonial violence and striving to practice solidarity with Indigenous peoples by building relationships rooted in ethics of social justice and decolonization. These responsibilities exist in my life across and beyond professional and personal realms. They drive my actions as a clinician, as an organizer, as a community member, and they played a role in why I wrote Fighting for a Hand to Hold, Confronting Medical Colonialism Against Indigenous Children in Canada. So some of the objectives, I guess, for the session today are one, to summarize how medical colonialism, including anti-Indigenous systemic racism, persists in healthcare provision today by using the 2018 A Hand to Hold advocacy campaign as a case study. Two is to review the historical context of genocidal medical violence against Indigenous children in Canada, including its implications on healthcare education, research, and clinical care today. Three is to identify the roles that students, educators, clinicians, and researchers can play to engage in decolonizing medical education, research, and healthcare using a social justice approach. I guess I want to be clear that I'm really approaching this from the perspective of a healthcare provider, someone who's been involved in or been working in the clinical setting for many years. And so one of the purposes for these kinds of sessions is really for those of us, especially those of us who are settlers, working in the healthcare system, to basically, I guess, look ourselves in the mirror as we move forward. So in terms of disclosures, I have no conflicts of interest to declare, except as was mentioned, all of my authors' royalties are directed to pre-designated organizations in support of Indigenous children, youth, and their communities. And so these are the 6 organizations that all of my authors' royalties go to directly, and that's actually written into my contract with both publishers in English and in French. So I just wanted to make sure that that's recognized. In terms of other recognitions and acknowledgements, I think it's important for me to acknowledge to people in particular. There's many people, obviously, that play an important role whenever someone writes a book, too many to name. But 2 people in particular I want to acknowledge. One is Cindy Blackstock, who I'm sure everyone here knows. It's from the Gitxsan First Nation, Executive Director of the Child and Family First Nations Caring Society, who's been a tireless advocate for Indigenous children in Canada for decades now. And she kindly wrote the foreword to the book. And I also want to thank Ellen Gabriel, who's from the Kanien'kehá:ka Nation, from the community of Kansasdage, who was one of the spokespeople for her community during the siege of Kansasdage, also known as the Oka crisis in 1990, and has continued to be involved in climate justice, Indigenous rights, land back, among other movements since. And she kindly wrote the afterword to the book. And I always tell people, if you are going to read the book, then please read all of it, including the foreword and the afterword, because I would have written it differently had they not made their contributions. And of course, I think it's important to acknowledge and thank the many families that spoke out during the Hand to Hold campaign. I will go over the campaign shortly. But as many of you can imagine, in any context, it's very difficult to speak publicly, to speak out about issues, about injustices. It's that much more difficult when we do so during a time when our child is sick or injured, or when there's been a death of a child. So many of these families did exactly that, and without their contributions and involvement in the campaign, which really gave it a sense of urgency and a sense of humanity, I'm quite certain that the campaign would not have been successful as quickly as it was. So just to provide a bit of context for the campaign, as was mentioned earlier, there in the province of Quebec, since the early 1980s, there was a practice in place to prevent accompaniment of patients during medical air evacuations. And that was actually a practice that was in place across the board throughout the province. But what we saw, and this map shows this, is our catchment area. So at the Montreal Children's Hospital, the McGill University Health Center. So the area, this is the map of Quebec, and the area in red are the areas we are responsible for. And so you can see here that in northern Quebec, so Iwishi or James Bay Cree Territory and Nunavik, which are the homelands for Inuit in northern Quebec, these children would come to us, and when they were sent by Challenger plane or air hospital, flying hospital, they were sent alone. So we saw these kids consistently coming alone for years and years and years. And what ended up happening is basically in the summer of 2017, over a span of a few weeks, there were 2 kids from Nunavik who were transferred for emergency care to the Montreal Children's Hospital alone. One was a preschooler with suspected abdominal and head trauma after falling off an all-terrain vehicle, and the second was a school-age child with an esophageal foreign body, a coin that was stuck in the throat, basically. And these 2 kids came during shifts that I was working in the emerge as the charge emergency physician. And for whatever reason, I think probably complicated reasons that may explain it, some of which I don't still know, these 2 kids really prompted us to look into things and to start questioning this practice, this long-standing practice, which saw, hundreds of kids every year sent down for care from rural areas to southern hospitals alone. And so you can imagine how frightening and traumatizing that this would be. So this would be like the trajectory that a child would take. You can see on the left this big kind of cold, plain, sterile environment surrounded by a transport team that doesn't speak, often would not speak the language of a young child, who typically would speak either Cree or Inuktitut, depending on where they're coming from, and then would be sent down to us at the children's, where they were again surrounded by a bunch of people, well-intentioned, of course, but again, who would not be able to speak their language, who were poking and prodding at them, doing investigations, labs, etc. And all the while, these children were alone with no, hand to hold, no parent accompaniment, no caregiver. And so we basically, in developing the campaign, obviously a lot of this was coming from the parents and the families themselves, but also amongst us, healthcare providers, nurses, physicians, pediatric residents, social workers, research assistants. We kind of talked about all this stuff, and we, distilled some of the major issues that we saw with this practice. So issues for healthcare provision, you can imagine clinical care would be impacted. So we often, these kids were sent, we often didn't get a clear sense of their past medical history, past surgical history, what medications they may be on, if they had any allergies, this kind of thing. Consent was obviously impossible if the parent was not there. And sometimes even when we would try to call the parents, we were often not able to reach them, because what would happen is that the provincial government did pay for one parent or caregiver to be able to rejoin their child on the plane, and by taking the next available commercial flight. But you can imagine that if they're on a plane on the next commercial flight, then we can't really reach them to get consent if we have to do a surgery or whatnot. The other element is that the parent is often acts as a caregiver for the caregiver acts as a child advocate, sorry, in any circumstance, and certainly in these cases. What we saw, for example, were certain situations in which children were sent to us, Indigenous children were sent to us with really painful conditions, an appendicitis or a fracture of the forearm, and they had not received any pain medications during their transport. And when we asked why, then the transport team basically said, "Oh, but the child didn't express any pain." When we know that different children, individually, but also from different cultural contexts, will express pain differently. And so, when they came to us, we could tell that they were in pain. Several of my colleagues have worked in Nunavik, in Iwishi, and so they immediately got treated. But that means that they went several hours without pain medications for really painful conditions. And so if there was a caregiver that would have been able to accompany the child, then that would have been addressed. Another issue for healthcare provision is the psychoemotive trauma. So for any child coming to the emergency, I can tell you it's a traumatic. It can be a traumatic experience. For any child who's coming alone, it can be that much more traumatic and traumatizing. And then added to that is obviously the historical trauma of children being removed from Indigenous children being forcibly removed from their families and their communities. That adds another layer to the psychoemotive trauma, not only for the child but for the family and the community itself. And then there are other elements like patient safety, standard of care, physician code of ethics. We looked into the human rights charter and the law. We looked into more broad ethical questions and arguments. And then we basically developed the campaign along a kind of equity-based lens that during the campaign itself transformed into a social justice-based approach. And so just to give an idea of why these kids were disproportionately impacted by this practice, this is a map of EVAC, so Évacuation Aéromédicale du Québec. So that's the provincial organization responsible for medical airlift across the province. And what you can see is in red, green, and purple here are the coverage of the flying shuttle. So the flying shuttle had 2 nurses, but actually allowed caregiver accompaniment. And in black, what you see is the outline of the flight coverage for the Challenger plane or the flying hospital. And so, the flying hospital was available 24/7, whereas the flying shuttle was available once a day, once every other day. But what this meant tangibly is that if you had a child who had a fracture of the forearm that was relatively stable but needed definitive care in Quebec City or in Montreal, then that child could wait for the next, for the next flying shuttle to be transported down. And in this case, the child would be accompanied by a caregiver or a parent. Whereas if a child was in Salouet or, in Kuujjuaq, for example, with the exact same condition, they would not be allowed to be accompanied down south because the only way for them to come down south would be by flying hospital, because there was no coverage in the northern half of the province with the flying shuttle. So now we start seeing why Indigenous children from northern Quebec were disproportionately impacted by this practice. Another reason is that we know, there's plenty of studies out there that show that Indigenous kids in Canada are at higher risk of different, illnesses and different conditions that predispose them to needing to be transferred for medical care in certain cases. And that's also the case here in Quebec. This is a few years old, but it's still the case that children from Iwishi or Nunavik have higher rates of respiratory tract infections and injuries, for example. And both of those conditions are reasons that necessitate medical air evacuations. So you can imagine that if there's conditions that cluster that require medical air evacuations in a given community, and that that community can only get medical air evacuations by the flying hospital or Challenger plane that does not allow for parental accompaniment, then these children are therefore going to be disproportionately impacted by this non-accompaniment rule. So why a social justice approach? Basically, there's the whole issue of social determinants of health, which are, kind of a concept that's been, if not elaborated, certainly endorsed by the WHO, the World Health Organization, and rightfully so, which basically looks at, the conditions that we live in, that we play in, that we work in, and how that has an impact on our health and well-being. And what we can see is, and that's totally true. And we are taught this in medical school now, to a certain extent, social determinants of health. But the problem is that we don't talk enough about the upstream factors, so the structural determinants of health, that actually create the conditions for the social determinants of health more downstream. And so when we're talking about the structural determinants of health, we're looking at the socioeconomic and political context. So governance, macroeconomic policies, social policies, and public policies, including healthcare and education, but also culture and societal values. And I bring that up very intentionally because something like, Indigenous systemic racism plays a role in this. In fact, after that first child I mentioned who fell off an ATV, an all-terrain vehicle, who I cared for, that child ended up doing okay. But a few days later, a colleague of mine had emailed asking, how the child did. And one of the things that came out, I was expressing my frustration that this child was sent alone. And my colleague basically, in a very succinct reply, essentially by email wrote, the root cause, unfortunately, is systemic racism. And that was really interesting for me because I hadn't really framed it that way yet. But certainly that does play into this practice and how disproportionately it impacted Indigenous children from northern Quebec. But the other issue that his comment raised is, how can kids counter systemic racism? What voice do Indigenous kids have when they're often considered to be, quote unquote, voiceless? And so one of the things that often comes to mind for me is thinking back to this line by Arundhati Roy, who said, "There's really no such thing as a voiceless. There are only the deliberately silenced or the preferably unheard." And in fact, as it turns out, when we dug a bit deeper into this, it turned out that there were many people who were unheard or silenced. So there have been many unsuccessful attempts in the past to change this, including as early as the 1990s with a petition signed by hundreds of people in Inuit communities to put an end to this practice, and it was basically ignored. And then there were multiple attempts since then. But ultimately, one of the points I try to highlight in the book is that every request by a caregiver wanting to accompany their child on a medevac flight that was refused, which happened, on almost, certainly a weekly, if not a daily basis, was a missed opportunity to right a historical wrong. So in light of all this, when we're developing the campaign, one of the, things that guided us was this line, or the spirit of this line by the late elder Ella Shukpuyungi, who had shared this with a colleague of mine several years ago. And she'd said at a conference, "We Inuit know that we have to work with you, Halonat, for a long time still, and we agree with that." I guess Halonat means either white person or non-Inuit or settler. But if you wish for that relationship to work, to be fruitful, you will have to listen to us. And that's what we tried to do. So what we ended up doing is basically writing a letter that was sent to Évacuation Aéromédicale du Québec and several levels of government, including the Health Ministry and the Transport Ministry in the province of Quebec. That was, I drafted the letter and it was co-signed by the division director in the emergency department, as well as in the pediatric intensive care unit. And in the letter, we, talked about all the stuff I mentioned earlier in terms of, the impact on clinical care and all this stuff, but we also talked about the historical reality of abuses, including the fact that, Indigenous children have been ripped away from their families and communities through residential schools, through youth protection, and also through the healthcare system itself. And so one of the things that we tried to highlight was that, allowing this kind of practice to continue risks establishing or perpetuating suspicion and distrust towards the healthcare system in Quebec. So we proposed an equity-based lens that evolved into one that adopted a social justice lens over the course of the campaign. So unfortunately, we did not get any commitment for change by EVAC or by the government. There was an acknowledgement of the letter, but nothing, significant in terms of a commitment over a fixed timeline to change this practice. And so a few weeks later, we launched the campaign. So the Hand to Hold campaign was launched on January 24, 2018. It made a huge splash, media splash, front page news in both English and French language media. The initial response by then Health Minister Gaétan Barrette was basically to say that we don't have any plans of changing anything. And so we, ramped up the pressure. There were editorials kind of all over the place in support of the campaign, including in the Globe and Mail by André Picard. Healthcare providers, including from the other pediatric hospital in Montreal, Saint Justine, got on board in support. The Canadian Pediatrics Society came out in support. And then a few weeks later, basically, the health minister called a press point and said that we are actually going to change things imminently. Unfortunately, over the next few weeks and months, that did not happen. So all these children were still being systematically sent alone. And so families, spoke out publicly against this. This was in March. And then again, another family spoke out publicly a couple of months later in May, again, making, front page news, keeping this issue in the media and the public sphere. To the point where we were even invited to submit a opinion piece for The Guardian. So then this issue became kind of global news. Finally, after ongoing pressure, a lot of ups and downs, the provincial government issued an actual written policy to allow for caregiver accompaniment. Because as it turned out, thanks to the work of some great journalists, we found out that there was actually never any written policy, preventing caregiver accompaniment. It was just a practice that just kind of passed on from one generation at EVAC to another. So now at the end of June, there was actually a written policy allowing for parental accompaniment. And a few days later, we actually received our first Inuk child who was accompanied by his mom. This was a child who had fallen off his bicycle and required trauma care. But it was really, really powerful for this child to be accompanied. It made a huge difference, obviously for the child, for the mother, but certainly also for the medical and trauma teams. So we were really hopeful after this, but unfortunately, as it turned out, anywhere between a quarter to half of kids who were transferred down in the months that followed were still sent down unaccompanied, including this child, whose family then, took out to speaking publicly about this to denounce that this was an ongoing practice, despite the commitment to change. Thankfully, by October of 2018, the new new policy was put into place across the board. And so since then, virtually all of these children are being sent accompanied across the province. We were worried during the pandemic that the pandemic was going to be used as an excuse to to claw back at this victory, basically. But there was really a cultural shift in AVAC, and they maintained parental accompaniment and caregiver accompaniment throughout the pandemic, which has been really amazing. So now there's only been maybe a handful of cases over the last few years where children have been sent unaccompanied, but that's not even been as a result of IVAC's, it's not a fault of IVAC, it was often for other reasons. So clearly the campaign, was successful in achieving its main goal, which is to make sure to put an end to this practice that disproportionately impacted Indigenous children from Northern Quebec. So as I mentioned, there were a lot of ups and downs during the campaign. One of them was this one that made provincial and national headlines even, where the health minister made comments that perpetuated racist stereotypes against Indigenous peoples. So I'm just going to share that a 2-minute news report that was ran by CBC around that time, and I'll provide a bit of context to understand, I guess, what was going on at the time. Give me 2 seconds. I'm just going to pull this up.
A rule that prevented sick children from traveling with their parents aboard medevac flights has been widely criticized in Quebec. After recent pushback, the government yielded and promised to let parents on board. At a community event at this mosque, the health minister was asked why that hasn't happened yet. CBC obtained a recording of his response, where he guaranteed someone intoxicated will be kicked off of a flight in the next 6 months.
When someone will not be made allowed, not allowed to get the flight. Why? Because no one agitated, whatever influence will get us the plane. Any cost. That will not happen. That is all the time.
Those words led to a chorus of condemnation.
To have comments like that by a minister is totally appalling and unacceptable. We're going to demand that the minister resign from his position.
The head of an organization that represents Inuit in Quebec's north says he needs to apologize, and I don't think that will be enough. He needs to go. The trust is gone. Barrette backpedaled today, at first saying that people wrongly assumed he'd been talking about Indigenous people when he meant it more generally. Then later he offered this as an apology.
I can understand the sensitivity of that and the reaction, and I apologize for that. I'm quite sorry about that, but at the end of the day, can we move on?
The Premier is standing in solidarity with his health minister as a provincial election looms.
I think he is sorry that his words have been interpreted that way. I suggest that we leave it there.
Barrette did call the mayor of Kuujjuaq to apologize. The mayor says he does not accept the apology. He's demanding that the minister resign immediately. Jayla Bernstein, CBC News, Montreal.
So I share that for a few reasons. I'm just going to go back to my presentation. One is that, I don't know if people know, but Gaetan Barrette is a physician, as a radiologist, and was the health minister at the time that this was happening. And so, the fact that he was able to make these comments essentially in complete impunity, I think is very telling, and also very concerning. Because he did make them in complete impunity. He was actually, despite the calls for his resignation, he ended up completing his term until October of 2018. In fact, he was even re-elected, even though his party was not. So I think, it's very concerning because of what kind of message it sends to the entire healthcare system that, a health minister, a physician can make these kinds of comments that perpetuate anti-Indigenous racism and essentially get away with it. In fact, I was invited to testify as an expert witness during the coroner's inquiry into Joyce Echaquan's death in May and June of 2021. And I brought up this issue, this exact example, because what I tried to highlight, and I obviously did not try to make a cause-effect relationship between the two, but what I did try to say is that, the fact that he was able to make, these comments essentially allowed for that kind of behavior to exist within the system, meaning that if he had been reprimanded when he made those comments, maybe it would have sent a signal across the healthcare system that there's zero tolerance for, for discriminatory behavior. And maybe, just maybe, then in September of 2020, when Joyce Echaquan required care and instead was treated with disdain and with violence at a hospital moments before her death, maybe that would have happened, maybe her treatment would have been different. Maybe she would have been actually treated with the care that she deserved and she needed. The other reason I share this video is because of the fact that, at the end of the clip, Barrett basically said, at the end of the day, can we move on? And I think that's something that I've heard, when I was a medical student, as a resident, and I still hear it as a staff, when it comes to issues affecting Indigenous peoples. And I think the response is basically, at the end of the day, we cannot just move on because there are ongoing impacts of colonization and genocide. And I obviously don't have the time to go over all of these issues, but I do want to address systemic racism in healthcare. So just to give some statistics that I mentioned in the book, that are really horrific and horrifying, is that in Canada, infant mortality among Inuit is close to 3 times higher than among non-Indigenous infants. The mortality rate of status First Nations youth between 10 and 19 years of age is at least twice as high as compared to the national average for the same age range. And among Indigenous girls and young women between 15 and 19 years of age and living on reserve, this rate is almost 5 times higher. And in Quebec, the infant mortality rate for kids, for children in Iwishi and in Nunavik is anywhere between 4 to 6 times higher than compared to the rest of Quebec. And in fact, in Nunavik, this is actually probably 7 to 9 times higher based on more recent data that just came out last year, published by Le Devoir. So things are not getting better; they're actually getting worse. And so that, those are the realities of like social determinants of health and structural determinants of health. And one of the points that I try to raise in the book is inequalities in healthcare follow the fault lines of societal injustices. And so long as there are societal injustices, then inequalities in healthcare will persist. And so that means, addressing the structural determinants of health. And one of the core structural determinants of health in the context of healthcare provision for Indigenous peoples is medical colonialism. And so medical colonialism is kind of the way I tried to frame it in the book is, draws on the work of many Indigenous and non-Indigenous historians, activists, scholars, including several people who are in attendance today, and certainly much of the work of Mary Jane as well. And the proposal is that medical colonialism is a culture ideology rooted in systemic anti-Indigenous racism that uses medical practices and policies to establish, maintain, and or advance a genocidal colonial project. And I use the term genocidal very, very intentionally, because for those of you who have not yet read the book, in part 3 of the book, I basically divide each of the chapters according to the 5 acts that constitute genocide according to Article 2 of the United Nations Convention on the Prevention and Punishment of the Crime of Genocide. And so I'll just try to quickly highlight some of them. I can't obviously do an exhaustive treatment of this in a few minutes, but I will try to provide a bit of an overview in terms of some of the examples I illustrate in the book. So killing members of the group, I highlight the work of Peter Henderson Bryce, who was a physician and public health specialist in the early 1900s, whose work basically showed that Indigenous children were dying after passing through residential schools. Based on his study, anywhere between 25% to 69% of kids would die after having passed through residential schools, mostly in the prairies. And what I try to highlight is actually the role of physicians. So physicians actually screened many of these children. And so the ones that were identified as having tuberculosis, because that was one of the main causes of death, was tuberculosis, at the time, could have been prevented from entering these residential schools. And then once that didn't happen, once TB became, not only epidemic, but endemic in these residential schools, then physicians could have, through their screening process, could have at least prevented healthy children from going into residential schools. So that didn't happen either. So tuberculosis, for example, just, spread like wildfire, often going back to communities as well. And one of the points that I also try to highlight is that these physicians, including Peter Henderson Bryce, could have actually taken a clear stance against residential schools altogether, which he didn't do either. In fact, he, believed in the civilization, project, civilizing project of the residential schools. He just felt that it should be done better. And so this, I think, role that physicians did not play of calling for the end of residential schools is an example of how the medical establishment was, played an important role in this aspect of genocide. Two is deliberately inflicting on the group conditions of life calculated to bring about its physical destruction in whole or in part. And here I rely heavily on the work of food historian Ian Mosby, who showed how, among other experiments that were done on Indigenous communities, was the one where residential schools were implicated. So 6 residential schools, almost 1,000 kids, where they basically, scientists, doctors, dentists, nutritionists, basically took advantage of the fact that these children were starved and malnourished, to conduct these experiments to see whether vitamin supplementation or changes in diet would improve their well-being, which was obvious. They all knew that this was the case. So instead of calling for to ensure that these children were had adequate diets, they basically tweaked their diets for their own ends, for their own professional careers and to benefit settler society in terms of what knowledge was gained. Again, none of these people called for the end of residential schools, which is what they should have been calling for. 3 is causing serious bodily or mental harm to members of the group. And I think during the course, you've already addressed much of this. The picture on the right is from the Charles Campbell Indian Hospital. And so, there's been a lot of work done around Indian hospitals, including by Maureen Lux, historian, who I think I saw was attending today. Really important work to show how this was really an apartheid system of healthcare, where Indigenous people were often not treated in Western or colonial hospitals, and so were being treated in these Indian hospitals. So at its height, there were over 20 Indian hospitals, 2,000 beds in the 50s and 60s, and kids were also sent there, including for tuberculosis care. The average length of stay at a given point in time for tuberculosis care was around 20 months. So you can imagine how brutal this was for children to have been removed from their families and sent down for care, hundreds and hundreds of kilometers away from their families and communities. And in these hospitals, they faced, all kinds of abuse: physical, spiritual, sexual, psychological, emotional. And there are, several class action lawsuits now happening to seek reparations for that. Just for the sake of time, I'm going to skip some of these elements, but I do want to address in terms of imposing measures intended to prevent births within the group. The important work done by Karen Stote, and obviously the courageous speaking out by Indigenous women who were forcibly or coercively sterilized to denounce this practice, that in many cases is actually ongoing up until very recently. So one of the things that Karen Stote highlights is how there were actually legislation in BC and Alberta from the 1920s around to the 1970s that allowed for sterilization of people who were deemed unfit to have children, and Indigenous women and girls were disproportionately impacted by this, at least based on records that are available through Alberta and Alberta Sterilization Act. And then finally, forcibly transferring children of the group to another group. This is Act 5, and this kind of loops back to the non-accompaniment rule. So one of the things I try to highlight, relying on the work by Pat Grieger from a few years ago, is the tuberculosis epidemic among the Inuit. So what we know is that there was a ship called the CD Howe that would basically go to communities in Nunavik and Nunavut, on board all community members, screen for TB, and then if people were found to screen positive for tuberculosis, they were sent down, they were kept on the ship, and then they were sent down, as I mentioned earlier, to Indian Hospital and sanatoria across the country. So they brought down Quebec City, Montreal, and then often by train sent to Hamilton, Toronto, Edmonton, etc. Many of these children, were sent alone and never returned home. And relatedly, in terms of children not returning home in Quebec, for example, in the 50s, 60s, and 70s, there were children who were sent down to southern hospitals from different communities and different nations, Atikamekw, Anishinaabe, Innu, for things like, bee stings and pneumonia, fractures. And then those children were not only disappeared into, but literally by the medical establishment. So many of these families are still looking for these children that never returned home. And so an ongoing, impact of non-accompaniment practices. And so one of the main points that I try to highlight in the book is that, whether it was intentional or not, the ongoing persistence of the non-accompaniment rule into the 90s, especially after people were calling for an end to the practice, basically made it a practice of medical colonialism. And so what allowed it to exist was basically a culture, as I mentioned, in terms of the proposed definition or the proposed framing of the concept, is really this culture that allows it to happen. One of the lines that Maurice Sinclair often uses speaking about systemic racism, I'm sure everyone knows who Maurice Sinclair is, but he presided over the Truth and Reconciliation Commission of Canada, former senator, former judge. And he basically says, systemic racism is a racism that's left over after you get rid of the racist. And I think it's a really important way of understanding how systemic racism functions. The one caveat I would say is that individuals have a powerful impact on framing and on structuring systemic racism. So as I mentioned, the health minister from a few years ago, but also if we go way back, people like William Osler, so considered the father of modern medicine. What people often don't know about, he's like worshipped. He has a mythology around the world actually developed around him. But what people don't know is that he was, he held racist and sexist views, including around Indigenous women. And he claimed, he had white nationalist perspectives calling for Canada to remain a white man's country. Similarly, there are other physicians who played, important roles in some of the aspects I just mentioned. So Percy Elmer Moore was, played an important role of an architect in terms of the mass evacuations of Inuit for tuberculosis care. He played a role in the Indian hospitals, in the nutritional experiments, and so did, in terms of the nutritional experiments, so did Frederick Tisdall, not necessarily with the residential schools, but other nutritional experiments that were conducted on Indigenous children and adults in different communities in the 40s and 50s. And so all of this stuff, people will say, oh, but that's a thing of the past. But the reality is that it's not just a thing of the past. So this is actually an example of how some of these things come back and persist. What many people also didn't know about Osler is that he'd actually essentially stolen the skulls of 4 Indigenous people, then brought them to his mentor Rudolf Virchow in Germany. And only recently now is attention being drawn to that. And so Rick Hill, who's from Six Nations, is working on bringing back those skulls and bringing them back to their community. So we can see how the echoes of what Osler did continue to be felt. But in other ways, those cultures are also felt to this day in different ways based on clinical experience, whether it's pain management, whether it's how people, including kids, are triaged in the emergency department, whether it's for pain. As I mentioned earlier, children, Indigenous communities are treated, oftentimes treated worse than white folks, for example. And we see this in medical education as well. So, or medical schools, where Indigenous people and Black people are disproportionately, are disproportionately underrepresented, or significantly underrepresented. And what we are not taught, for example, in medical school, is that there are reasons for that beyond, cultures of systemic racism. There are legislations that was, that existed through the Indian Act, for example, up until at least the 1960s, that prevented Indigenous First Nations people from getting a medical degree without having to give up their status as First Nations. So basically, once they would, go into medical school, they had to give up their First Nation status if they wanted to complete and get their degree. So you can imagine how that's going to have an impact on, First Nations people getting into medical school. So I know I have just a few minutes left. I'm just going to share this this video, and then I have a few slides after that. This is a 2-minute video that I think is really important shows how cultures exist in medicine, and these cultures of impunity exist. And so the first part will be a little bit in French, but the rest is in English.
My name is Alika Lafontaine. I'm an Ojibwe Cree anesthesiologist, born, raised, and trained here in Saskatchewan.
Alika Lafontaine est le premier médecin autochtone qui deviendra bientôt président de l'Association médicale canadienne. Non seulement il reconnaît la responsabilité des médecins dans la pratique des stérilisations imposées, il a le courage d'admettre sa propre expérience.
As providers, I'm an anesthesiologist. We sometimes engage with patients and we mistakenly draw the line of where our opinion ends and the patient's power to make decisions starts. I was likely a part of some of these experiences as a trainee. I remember in residency that I would sit during C-sections and, the surgical team would lean over and say to the patient, we're going to go ahead with clipping your tubes. And, tears would start to well up in the patient's eyes and they'd start to cry. And keep in mind that I've experienced racism myself. I have family who's been racialized. I've had racial experiences with my children when I brought them in for care. I sat there and thought to myself, maybe my spinal anesthesia is not working properly. It never occurred to me that a patient was not given the space to make an informed decision about something so significant in their care.
So I share that for a few reasons. For anyone, for people who don't know, Alika is the current president of the Canadian Medical Association, and has been working on these issues of confronting systemic racism and discrimination for years and years. So I think it just highlights how even someone like him can end up being part of this machine unless we become really aware. And so it ties into this line from a former pediatric resident who had written me a few weeks after the campaign was launched. She said, I can't even recall all the times in my residency that I was in a situation where this policy affected a child I was taking care of. We knew it was the rule, we knew it was awful, and yet we just kept going. And I think one of the reasons why I ended up writing the book is really to make sure that we do not just keep going. And yet 4 days after the book was published, we learned of the death of Joyce Echaquan. And on the picture on the right, we see one of her younger kids, as well as her eldest, Marie Wasiana, and her spouse, Carol Dubé, both of whom testified during the coroner's inquiry, really powerful testimonies. And during the inquiry, we heard that her death was basically avoidable. The coroner, in her conclusions, said that systemic racism played a role, and said basically that in response to a journalist that if she was white, she would still be alive. And so the coroner issued several recommendations that are really, really important, including putting an end. Her first recommendation was putting an end to systemic racism in Quebec, which the Quebec government to this day doesn't even acknowledge the existence of. And so recommendations are important, but as Cindy Blackstock has said before, good intention and convictions are not enough. It is what we do in our actions that is most important. And so what I'm going to leave you on is actually this vigil that a bunch of us in healthcare organized through the Caring for Social Justice Collective, among others, as healthcare workers, the year following Joyce Echaquan's death, the 1-year anniversary in Montreal, where we called a vigil, and her family came. Here we see her parents, many members from the community drove down to attend. There are many people from the city of Montreal who were there. And we made it a priority to make sure that the people speaking were all Indigenous and with a priority for Indigenous healthcare workers. So this is one of them, my colleague and friend, Dr. Raven Dumont-Maurice, who's a pediatrician, who's Algonquin from the community of Kitigan-Zibi. And in her speech, she basically wrote, "To Joyce's children, we heard your mother's words loud and clear. Her last moments also served as an act to protect you and future generations. We will continue to work hard to make sure that our healthcare systems are places of respect and humanity at all levels, for everyone." And ultimately, that's really what it comes down to. So for, I think these things are important to highlight, to organize around beyond the hospital walls, like the vigil, endorsing and supporting Joyce's principle across Quebec and across Canada. For anyone who does not know, I would encourage you to look up Joyce's principle. It's basically a blueprint for ending systemic racism in healthcare. And beyond, the hospital walls, beyond the university walls, I think it's also important to take to the streets when necessary in support of Indigenous-led movements for self-determination, for autonomy and sovereignty. Thank you very much.
Thank you so much for that talk and for all of the resources that you've given in that PowerPoint as well. So I want to state again that now we're going to be turning to the question period. So this is going to be open for the class only. So we're going to say goodbye and thank you very much to those who came on Zoom. And we're going to open up the discussion for the students in the class. If anybody has any questions or any points about the presentation they want to talk about further, or points about the book that they found, really helpful or help them see, I guess,